I'm Dr. John Kruse. I hope you've had a manageable week. And today I'm going to be talking about depression and ADHD. Stressing how big an issue this is. So the World Health Organization, when they're not busy battling the COVID epidemic, have said, and this has been true for several years now, that depression is the disease that causes the most financial distress, dysfunction, loss of income on this planet. And the reason for that is, one, depression is highly prevalent. Two, it causes a lot of dysfunction, lost work, lost lives when it's present. And three, it particularly affects people starting at much younger ages. A third of us in the US wind up dying of cancer, and yes, there are pediatric cancers, but by and large, that's a disease of old people towards the end of their productive work lives, and not that that's best measure of productivity. Some studies have suggested that up to a third of people who are diagnosed with depression do have ADHD. People who have ADHD probably have rates of depression that are 2 to 3 times higher than depression in the general population. Depression itself shouldn't be causing ADHD in ways we know, but again, two are commingling and working together. Three big facts seem to jump out from every single epidemiologic study looking at depression in terms of what causes depression and why it's there. So although we cannot find these factors in absolutely every individual, the 3 factors that jump out in every single study that's looking at it suggest that most people with depression have some substantial trauma in their first decade of life, and trauma can be parents separating, important figures dying, important major injuries. And separation of parents, even if it's completely amicable, is a trauma at a psychological level. Genetics is the second one. So most people with depression have depression in other family members. There's a strong genetic contribution. It's actually not as strong as the contribution of genetics to ADHD. It's a strong one. And then the third factor that jumps out in the studies is having another trauma in the 6 months prior to an episode of depression starting. And more recent trauma does not necessarily have to be on the magnitude of loved ones dying or serious physical illness. So certainly the COVID epidemic itself, loss of jobs connected with that, or loss of income, even if you have part of your job still present, the trauma that's being stirred up by the racial justice demonstrations going on, all of those could be trauma significant to trigger depression in people who are already predisposed to that. A little bit about depression. Depression isn't just feeling sad. It has to be a pervasive state that's lasting several weeks at a time. Almost always other negative feelings are accompanying it. So excessive guilt, some people have suggested maybe even more diagnostic for depression than just feelings of sadness. Social isolation or wanting to withdraw yourself from other interactions is characteristic. Inability to feel joy, which is a little different than just feeling sadness. And the official word for not being able to feel joy is anhedonia. And depression is usually accompanied by physical changes. So decreases in energy level, disruptions in sleep, which can be either sleeping less, insomnia, or hypersomnia, sleeping much more than usual. Eating disturbances, those can also go 2 different directions: decreased appetite and weight loss, or overeating and weight gain. And decreases in libido are commonly found in depression. There are also many people who are diagnosed with having depression by practitioners who are more familiar with depression than they are with ADD, who mistake the emotional dysregulation of ADD for depression. About 2/3 of people with ADD have objective measures of emotional dysregulation, and of people with ADHD who have the hyperactive type, even higher correlation. Emotional dysregulation tends to create emotions that come up much larger, much more explosively. Unless there's something distracting the person, they can become locked or fixated on those negative feelings, and that can happen for days at a time, usually not weeks at a time, again, if it's just emotional dysregulation connected with ADHD. But in the midst of it, that person can feel horribly negative. What's helpful for getting someone out of it, if it's emotional dysregulation of ADHD, is remind them that they have ADHD, to remind them, just as with the cognitive attentional focus, where they can be staring at the tree in front of them, need to step back and realize they're in a forest. Same phenomena can be going on at emotional area. So if they're looking at something that's happened, that's tragic, that's sad, that's horrible, that they're feeling really down and low, reminding them there may be other things in their life and that their ADD itself may be causing them to focus on this feature of what their environment, while they're regarding the wealth of other things that may be good and positive. That intervention itself can often help them get out of that negative state. Whereas if it's depression, it's less likely to be powerfully effective. William Dodson has written extensively about what he calls rejection-sensitive dysphoria. This has been written about a lot in Attitude magazine and other places. His formulation of it is that kids with ADHD get all sorts of negative feedback growing up, that they're doing this wrong, that they're bumping other kids, they're causing accidents, they're causing problems, they're noisy when they should be quiet, they're active when they should be sitting still. And he claims that this predisposes them to be hypersensitive to criticism when they get older, and that criticism taps into a whole host of deep-seated negative feelings, which can come out in explosive anger, come out in extreme sadness. However, there's two things that come out in some of his writings where he says that one is that virtually everyone he's ever treated with ADHD has rejection-sensitive dysphoria, and that is categorically not at all my experience. I see some people who have that, and I see many people with ADHD who have actually particularly positive, highly resilient attitudes. Everything falls off them like water off a duck's back. So I don't think that all people with ADHD are suffering from rejection sensitivity. And secondly, he makes this as something unique to ADHD. I would feel strongly that one is almost anyone on the neurotypical spectrum, the autistic kid, the gay kid, the left-handed kid, all are growing up with a sense of feeling different, and depending on the society they're growing up on, but it's still by and large in American society, they are picked on, they are told they're wrong, they're told they're different in a bad way or weird or strange. I think the same constellation of processes that he describes for creating rejection-sensitive dysphoria and ADHD exists for a host of other people who are neurotypical. Getting back to depression, again, which can coexist with ADHD. Before jumping into medications, even though I'm a psychiatrist, often prescribes medications. I've seen medications be life-saving. And suicidal depressions, I've seen them be powerfully helpful before. But before jumping to medications, I always start with what I call the big four and when I was talking about scheduling. And that's sleep, eating, exercise, and meditation. So depression measurably disrupts sleep, but disrupting sleep measurably puts you more at risk for developing depression. Studied both in bipolar depression and in unipolar, where someone only ever gets depressed in their life. Regulating sleep, making sure you're getting close to 8 hours of sleep, not just 8 hours, the same 8 hours every night, even though I'm not a big fan of sleep agents. Sometimes a sleep medication before starting an antidepressant, or sometimes in conjunction, measurably helps get someone out of depression faster. In terms of eating, I'm not going to say too much. There's a whole industry on eating certain foods, and that's going to cure your depression. I think there's a few supplements like fish oil, which have, at least in a number of studies, seem to be beneficial for treating depression and anxiety. And I've seen a handful of patients where those seem to be powerfully helpful, and a much larger number of patients where those seem to be moderately or mildly helpful. But I think if it were simple as you eat fava beans every Tuesday or avoid grapefruit, I do not think that too many simple dietary changes are going to have a huge impact. Otherwise, we would be seeing huge cultural differences in rates of depression depending on dietary factors, which we don't see, actually, as a gross overstated rule. Part of that is that one is what we eat doesn't automatically go into our brain. There's blood-brain barrier. two, that some of the things we've seen in the laboratory system. So if you feed someone a specific diet, rich in certain amino acids, deficient in others, you can actually cause a serotonin deficit in the person's brain, and that can evoke depressive feelings in certain people. Someone eating either plant-sourced proteins or animal-sourced proteins is not going to get such a skewed sampling of amino acids. Again, you can do it in a laboratory situation, but eating general plant sources or general animal sources of protein, those protein sources break down into a pretty broad spectrum of amino acids that you need to build up your own proteins. So the other two pieces of the big four are exercise. There are several dozen studies now looking particularly at running, and that seems to be an effective intervention for people who were sedentary before they became depressed in terms of treating depression. I don't think that there's anything special about running, although there might. It's just that it's easy to standardize across testing centers and across individuals to make sure, are you running 20 minutes a week, rather than finding access to a gym and measuring different aerobic exercise or weight-bearing exercises may be harder to standardize. And there's growing evidence that meditation-based practices can have both preventive effects in terms of lowering your propensity to getting depressed and may be helpful in getting brains out of depression. Beyond the basic four, we have a number of medications. What I'm going to say there is, again, talking to the ADD component, is that the stimulants, which are the mainstay for medication treatment for ADHD, most of them, including particularly Adderall and Ritalin, have extensive histories of being looked at for treating depression. And they work, and they're fast, and they're effective. And it sort of puts a damper on the whole hullabaloo around ketamine of the last decade. That repeated claims, even in the psychiatric literature, about 90% of things I've seen said, ketamine, the first thing we have that immediately gets rid of depression. Completely wrong. We have studies going back 60 years. Adderall gets rid of depression within a day or two. Now, one critical difference is with ketamine, usually a single dose, the effects as an antidepressant last a few days to a few weeks. Whereas with the stimulants, when they work for depression, you tend to keep needing them. So it's having the drug in your body. Blood levels of it do seem to correlate with the antidepressant effect. There are a host of other biological interventions, transcranial magnetic stimulation, electroconvulsive therapy, deep brain stimulation, vagal nerve stimulation, cranial electrical stimulation, which are little devices with very low voltage currents, all of which have moderate to very good evidence they're helpful for depression. I won't talk about them more right now. I'm going to jump and spend the last few minutes on cognitive behavioral therapy. So cognitive behavioral therapy, which is teaching you how to essentially reprogram your brain. And it's based on the idea that your brain is in charge of all your emotions, in charge of all your behaviors, and in charge of all your thoughts. And all three of those can interact and affect the others. Usually we think of how you're feeling is going to change how you behave. You're going to stay in bed rather than going to work. And how you feel may change your thoughts. So you may become more focused on the negative about your spouse or partner. But it's not just a unilateral feelings affecting behaviors and thoughts. Each of them affect the others. So how you think measurably can have an impact on how you wind up feeling. How you think can change how you behave, and how you behave can change how you act and how you feel. And cognitive behavioral therapy focuses on cognitions or thoughts and behaviors because most of us have much more conscious ability to change those and thereby change feelings. And I'm going to talk a little bit about a subset of cognitive behavioral therapy called behavioral activation for depression. And it encourages people to get up or schedule some and uses CBT, cognitive behavioral tricks and tools to get them out and engaged in doing pleasurable activities. And measurably, our CBT approaches as a group have clear and robust antidepressant effects that are as robust as the antidepressant effects of our medication. They do tend to work substantially more slowly than the medications do, so on several weeks to a few months. On the other hand, they have a much better track record for looking how well people do after they stop treatment. So after stopping medications, the longer out you go, higher rate of recurrence to depression occurs. With CBT, that recurrence of depression seems to be much lower than it does for people who've stopped medication treatment. Part of why behavioral activation may be particularly effective, and this is a finding in the last few years. In the last few years, we've been shifting in brain research from focus on specific areas like the hippocampus or the prefrontal cortex or the anterior cingulate cortex to looking more at networks and how different parts of the brain are connected to subserve different functions. First few years of studying networks in MRI and other machines, functional MRI machines, they would instruct patients to do a certain task to look at what circuitry was activated by doing that task. And then as a control, they would tell the person, well, just sort of think of nothing. And instead of just sort of random nothing being activated, it turned out that telling someone to do nothing activates a certain system, which is called the default network. And it's called the default network, maybe not the best name because that was the default used as a control for these studies. The interesting thing that's coming up regarding depression is that people who tend to wind up in depression have an overly connected, overly strong, overly robust default network. So it's thought that default network system is what happens when you're ruminating, but the people who practice ruminating a lot are practicing being depressed or anxious. So there's a lot of overlap between depression and anxiety. Once you're in a depressed state or a highly anxious state, most people are aware that a lot of their time is spent in these negative ruminations, not productive problem solving, mulling over the same, and not in an OCD purely thinking over the exact same specific thought over and over, but thinking over a lot of negative thoughts over and over and over again and being locked. People talk about being stuck inside their heads. So behavioral activation focuses on getting people out and interacting. So it's engaging a very different network in the brain. And the more we can activate these salience and behavioral and engagement networks and deactivate the default network, the more powerfully we get people out of depressive states. So have a safe and sane week in an increasingly non-sane world.